This is the Medical College of Wisconsin's Oral History Project. I'm Dick Katchke, the Chief Historian. Today is September 28th, 2016, and we're talking with Marion Livingstone. And Marion is the Executive Director of Clinical Practice Services for the Medical College of Wisconsin. What led to your interest, when you look back in high school, college, when did you decide that you really wanted to pursue a career in finances?
That's an interesting question. Originally, I wanted to go into the sciences, and then when I was in college, I worked in the student accounts office and became really interested in everything that happens around finances with the students. And so that's what led me eventually to working in academic medical centers, and specifically in the area that I am now really focused on, which is physicians and reimbursement and all the things related to physicians and what makes them financially viable in the organization.
Well, now, you could have gone in many different directions. You could have worked for a Fortune 500 company. You could have, worked, for just a university. What was it about academic medicine that interested you, and what led to you working in an academic medical center?
I think back early in my career, I actually, my undergraduate, I was a psychology major, and I got a degree in psychology, and then I went back and got my accounting degree. But I think what really led me to wanting to work in an academic medical center is I love working with physicians, and I love working with people who are so smart and so focused, and that I can have an influence on their success. And I think that's what really led me to want to be in this field.
Now, before you came to MCW, I believe you were at the University of Pennsylvania?
Correct.
Is that the only academic medical center you were at, or?
Before that, before Penn, I was at a place called Allegheny. You
Sure.
might have remembered that
Yes.
organization.
Yes, in fact, if I'm correct, Allegheny was in Pittsburgh, based in Pittsburgh. It was in western Pennsylvania, but they took over the old Medical College of Pennsylvania and Hahnemann Medical School.
So actually, yep, that is correct.
Okay.
Good memory, Dick. So in those early years, I worked at Hahnemann. And I was in the what they call the academic finance office, and I learned everything about that, all the different funds flows that make that the entire academic medical center work, from the education to the research to the clinical enterprise. And then when then I went over to the Medical College of Pennsylvania and was an anesthesia administrator for that anesthesia department that later became combined. And then I had a stint at working and being the administrator for both radiology and anesthesia. So I learned a lot about those two departments in those roles.
And what led you to Penn?
So what led me to Penn really was there was an opportunity there to be their budget director of their medical school, and I looked into it, and things that back in those particular years, we were having lots of problems with what was going to happen to that combined entity with Allegheny. If you remember, there was quite
Sure.
a lot of
And
controversy then.
In terms of time frame, what years are we talking about? This was in the 1990s, I believe?
Yes, we're talking about 1998 or 1997 when I went to Penn, and I had the opportunity to be the budget director there, and so in their medical school. So I took that opportunity, which was really great. And but in that particular job, I was very much focused on the research and education, less focused on the clinical side, which I missed quite a lot. So.
Sure. But University of Pennsylvania has always been identified as one of the nation's top academic medical centers. So it was a great opportunity for you to really be working at one of the premier programs in the country as well.
Absolutely, absolutely. And when I was there, it's interesting, when I was there, my boss was Chris Copps.
Really?
Yes.
Okay.
Who is
what a
now
small world.
Yeah,
Sure.
who's now our senior vice president here at MCW. So had the opportunity to work with him. We were both fairly early in our careers at that point. And so it's interesting how people you work with, you can work with them again 16 years later.
Absolutely. We all hear stories about crossing paths like that. So,
Right,
yeah.
right.
How long were you at Penn?
I was at Penn for a little over 2 years. And I got recruited here by Whitkeefer, the executive search firm. And they were very aggressive, actually, at trying to get me to come out here for an interview. And in fact, I remember having a video conference with them because I finally agreed. I'm not going to come all the way out to Milwaukee. I really don't think I want to come here. I don't want to leave the area where I've been working, for over a decade.
And you're from the East Coast, aren't you, originally?
Right. I was born in Boston and grew up in New Jersey, and then worked most of my career prior to coming to Milwaukee in the Philadelphia area. So when I was approached, I was very hesitant, and but they really presented a really compelling opportunity here, and so I eventually came out. And a few weeks after that video interview, I came out and met with Rick Lofgren. You remember
Yes.
Rick Lofgren, who was
Rick was the head of the adult practice group at that time.
correct. And then Jane Shoemaker was the COO of the practice, and I met her. We had an interview in an airport, basically, and got to know each other over a cup of coffee, like in an hour and a half time frame. And it just, things really clicked. When you have chemistry with people, you kind of, I've learned to really go with my gut instinct, and it's been pretty true barometer of how things are going to go. And I really felt really comfortable with the people that I met here, and the large practice, the large clinical practice, and the opportunity to really focus on the clinical practice was really exciting to me after being very much in the research and education side of things.
Sure. As Dr. Lofgren and Jane Shoemaker laid things out for you, what did they identify as the opportunities and the challenges of the position?
Well, at that point, my role was billing and collections. That role has expanded since then, but really the issues were what can you do to take a pretty well-functioning enterprise for the revenue cycle and make it even better, and which really was intriguing to me, and I was very excited about it because many of the jobs I had in the Philadelphia market were the major thing was to take costs out of the system. That's what I was focused on. Take costs out. And that can be really tiring if that's all you do and you don't build anything. So they basically said to me, find ways to get us ready for when we need to take costs out. But you don't have to take costs out. You can just think about what technologies you can put in place to improve the processes and the efficiencies, which is a whole different way of managing that I had certainly had the education for, but never really was able to put into use. So that's really what excited me the most about coming here, and it really proved to be the case. I was able to do that. And the other thing that I got the feeling about when I met with both Rick and Jane at that time was they would let me be involved in lots of different things in the organization. I wouldn't just be pigeonholed in revenue cycle, and as other things came up in the practice, I would be involved. So that really was a promise that they made to me that they upheld, which was really very exciting as well.
And so in terms of time frame, this would have been around 2000, 2001?
Correct, yeah. I came in March of 2000.
Uh-huh. And at that point, as you said, the focus was primarily on billing and collections. How did your position grow as you were here then?
So I worked with Jane for about 3.5 years, and then she left and went to Florida, to University of Florida in Gainesville. So during that time, those 3 years was great. And then when she left, many of the areas that she had, I was able to also manage, including the managed care contracting area and the decision support area. So those two really broadened my responsibilities, and made the job a lot more interesting and challenging, and especially the contracting area, which I did have responsibility for back when I was in my Allegheny days. So I had a lot of experience in the contracting area for physician contracts. So I was able to use that and build on that here. In addition, I was, at that time, Marilyn Weber Lewis was here. Do you remember her?
Yeah.
And she reported to me also, and her role was very much clinic operations. And that, of course, has changed with Freighter hospital-based clinics now being the majority of the clinics. But back then, there were a lot more physician-based MCW clinics. So over time, I was able to work with Freighter, and we were able to do a combined office called Enterprise Registration and Scheduling that we were able to build, and I think that was a really great thing to do with our hospital partner. So I was involved in that.
You mentioned our hospital partner. This was an unusual situation in that MCW does not own our hospitals, and so we partner very closely with Freighter, with Children's, the VA. But did it create a situation then where you had counterparts that were working in the hospitals, or was all of the billing collections, handled by MC, or is it limited to just the physician billing? It was, handled by MCW.
Changed. That's changed too over time.
Yeah.
So today we have we do the billing. My area of CPS billing and collections does the billing for both our medical college physicians and children's specialty group practices, which are both billed under the MCW tax ID. But we also do billing for the community physicians group, which is a joint venture between MCW and Freighter, but the actual corporation is a Freighter corporation. And we also bill for the facility fees for our ambulatory surgery centers. So that has changed, that we do more work in conjunction with the hospital, so that we decide where is the best place for those resources to be deployed, and we've worked really closely with Freighter to be a good partner and provide those services when that made sense.
But that, you raise a good point in that it requires partnership, and that unlike an academic medical center that, like Penn, that owns the hospitals as well as the medical, the doctor's practice, it's a little bit different when they're separate owners like that. So you have to be a partner as well, right?
Right, except I will tell you this, my experience in working with both when I worked at Hahnemann and Medical College of Pennsylvania and University of Pennsylvania, there really is not a big difference whether you're a single tax ID or multiple tax IDs. You still have different areas with financial responsibilities for specific areas, so you still have to partner. And I don't think it really makes a difference. I think the relationships we've had with Freighter over time, there have been good years and bad years, but I think in large, if I were going to categorize it compared to the relationships that I had under one corporation, I think it's been better than the ones under one corporate ID, so tax ID. So I think that is a little bit of a...
You're absolutely, it could be misleading in that while you may be one entity, there's still going to be people that are overseeing the various components of the academic medical center, and there are going to be challenges on occasion, even as they have to work together.
Correct. And it really is relationships, all about relationships, building relationships, which is one of the things I've really enjoyed in my position here at MCW, is that I've been able to really work on that part of my career, and I really enjoy that building relationships part of my job.
Now, you mentioned managed care contracts, and as you talk about relationships, well, that's also a relationship. And when you first took on the managed care contracts here, how many different insurance companies were we contracting with at that time?
I think when I first started, it was something like 80-something, like maybe 82 different contracts. And we had a very unique market. Our market is still somewhat unique, but less so now than it was back in 2000. A lot of payers back in 2000 that made up the overall portfolio of our physician
So there really
contracts.
wasn't a dominant insurance contractor
There wasn't
then?
then. There wasn't then. In fact, we had this one insurance company called Health EOS, which started out, it was 40% of our business when I started in 2000. Now it's under 1%. So it just shows you how things have changed. And certainly United Healthcare has grown tremendously, as has Anthem. And we are now in the situation where we have just basically 3 players, really 2 fairly large players, compared to where it was back then.
But when you, back then, when you had so many different payers that you were dealing with, you were virtually always in negotiations then. Is that accurate?
Yeah, except that there was a lot less to negotiate.
Oh, okay. Okay.
There were like boilerplate contracts, and we looked at rates. And back then, everything was up every year. We were just negotiating what our escalator would be.
Sure.
That's very different than now, where it's a lot more of a challenge.
When you look back on when you first came to MCW, your first years here, you mentioned Jane Schumacher and Rick Lofgren. Who were some of the other people that helped introduce you to the MCW system, who helped you find your way around and became colleagues of yours?
I would say Doug Campbell was a big influence when I first came, and actually into I would say the first 10 years at least. I mean, since he was here. What year did he leave? 2005? I think 2000. No.
Well, he left in when Dr. Raymond, shortly after Dr. Raymond took on as president. So it would have been around 2011,
2010,
yeah.
Right.
Mm-hmm.
So, so during that period of time, certainly the last 6 years of his tenure, I worked really closely with him. And so he was very influential in, he was very, as you recall, Dick, he had a certain kind of management style that one had to be flexible to be able to work with, and I think.
But he was also very successful.
He was very successful,
and the people he worked with became very successful as well.
Correct. So I learned a lot from him, and hopefully he learned something from me. But it was a good relationship.
Sure.
And he really understood the finances and how everything worked here, and really helped me and to be successful. Absolutely. And when I needed something from him, he was always there for me, and I could talk things out with him. The other thing I did find here, which was very sort of, I want to say, refreshing compared to my days at the Allegheny organization, is every single time I asked a question about what we should do, we came upon an issue. It was always taking the high road, high integrity. It didn't matter if we were going to either A, show that we did something wrong, or B, put us in a worse financial position. If it was the right thing to do, we always did the right thing, and I always got support. The organization always had my back when we were doing the right thing, and that's a really important thing when you work at an organization that has that in its culture. I'm not quite sure how that happens. It has to be a lot of people having that same mindset of always taking the high road, always doing the right thing when it comes to whether integrity. Yep. And honesty, I think, are 2 qualifications that I've always found with the leadership, both my peers and people that were in higher positions. So that's been a really, really good thing. I will say my relationship with Dan Wickingham has also been very key. He's been in both the compliance role as well as in the interim senior VP role during the years when we've not had a permanent senior VP. So that's also been an extremely important relationship. And the compliance office here also takes a very different approach than compliance offices I've worked with before. They are, partners as well as helping us see things the way the government might see them, but they also are very much in a partnership with our shop, and I can call on Dan for anything, talk to him about anything, and know that it'll be confidential, know that he'll take a view that's maybe a little different than mine, which I really need to hear. So that's been really, really helpful.
Well, and another component of his office is risk management. And a lot of that is working with patients, and in some respects it's just clarity of communications, really listening to somebody who may have a concern or a problem, trying to work things out. And if you can address that early before things escalate,
Right.
It avoids problems down the road. And given the fact that your area deals with billing and collections, you are probably one of the areas where you can have some situations where you're dealing with unhappy people.
Correct.
And
Yes.
so,
Yes, it's very nice to have Dan Shop available to us, and working with them and coming up with our policies and procedures. And as you said, there are challenges. I mean, you know, you just look at the healthcare system, the healthcare finance system, and how it works in this country, how complex it is. Yeah, you need to have some really good policies and great scripting, and Dan has assisted us with both of those things, he in his office.
now we've mentioned Rick Lofgren. Who were some of the other physicians that you work with, and is it a challenge working with some really brilliant people whose skill set is not in the financial arena, and helping them understand how we have to navigate the finances of the practice?
Well, if I'm going back to the beginning of when I first started, I would say Dennis Maiman was probably one of the biggest voices of conflict, of dissatisfaction with what we were doing in billing and collections. And so my approach to him and his concerns was to meet with him pretty much weekly and go over exactly what we did, how we did it with detail, so that he could understand how our processes worked. And instead of working with anecdotal information and maybe what he heard from others, I wanted him to see facts. And that really made a huge difference. So between myself and Brian Birschbach, who's our Director of Decision Support, we sat down with him and his billing person on his side in the Department of Neurosurgery, and we were able to get him past all of this, I'm going to say hyperbole,
Sure.
into the facts,
Yeah.
and I think we won him over. So that trust became evident over time.
Did you find that your experience as a department administrator helped in understanding, well, how are things being approached from a departmental aspect, and this is how we have to help them understand what we're trying to achieve?
I believe that's very true. Understanding the various, conflicting strategies you have to have as a department administrator definitely helped me sort of meeting them, and also providing a service. And that's one of the things that I've always really tried hard to, as a leader of clinical practice services, in that
Okay.
the service,
Sure.
so that there's never a time when our organization feels like we are, that we have a life outside of providing service to our physicians and our administrators. I mean, that is our task. Without being successful there, we have no role. So we have to always put that front and center, providing that service. And that's a message that I continue to give to my staff and all the leaders, as well as the individual staff, in every aspect I can, because it's so easy when you are in the throes of, trying to get your work done, and you have different things you're trying to get accomplished, to forget that you're only there at the pleasure of the people that you're serving.
Now, Dr. Lofgren then left and took a position at the University of Kentucky. As there were transitions within the practice, how did you work with the new leaders that took on the practice? And also, as the children's specialty group was created, then you also had a new practice group that you had to be working with. So how did that all play out?
Well, I'll talk about the children's specialty group first. So when I first came, I was here maybe a year or two before Pat Radoszewski came on board as the chief operating officer. for Children's Specialty Group, and she and I have worked together really, really well, and I want to say that that's one of the relationships that I'm most proud of with Pat, and hopefully she would say the same. We have worked on so many things together. One thing I will say about Pat that I really love, I love a lot of things about her, but she brings me in to discussions that one would think might be outside of my formal role. So if they're having a discussion about funds flow or discussion about anything within the practice, the relationship that they have with the hospital, there are times that she'll bring me in to get my opinion, which I really appreciate. So it makes me feel like a valued partner. I do the same thing with her. Of course, there's plenty of business within Children's Specialty Group that we have. We've gone to the state together to do lobbying. We've done a lot of things together, and I feel really proud of that relationship. And it's built over the years. I mean, now we're talking 14 years working together, and it's a really great relationship. And trust is key there. In terms of the adult practice, that's been more challenging because I haven't had a consistent leader there to work with over 14 years. So we've had, and I might say too, in terms of Pat's side, yes, there's been different physician leaders, but she's been there as the chief operating officer.
She's the constant. She's
the constant. And even with all the different people that she's had, be it Mark Gorlick or Kevin Kelly or, Tom Sato now, all of those individuals have been, really strong leaders. And not to mention Joe Kirshner, our dean now. All these roles all these people who have been in these roles over the years have been fantastic leaders, and it's been a joy working with each one of them.
Well, in some respects, you helped prepare him for his role as dean by helping really understand the finances of the practice, which is an important thing that the dean of the institution the medical school has to understand. So.
And of course, he was very involved in our contract committee. Back then we had a contract committee, and Joe was on that committee. Mm-hmm. But what's been more difficult is on the adult side, because we've had so many different people in that role as the CEO, and that role has changed so much. Originally, when Rick Lofgren was in the role, and then he left, and then we had multiple interims. I can't even keep track of all the interims we had. We had Bill C. We had Kevin Kelly actually as an interim for a period of time. I think that was right after Rick left. So each one of those interim folks, as well as people that were there, like Peter Plantis, a short time, it creates a challenge when you're trying to bring somebody up to speed, and then it's difficult when they're not staying there beyond 2 or 3 years. It's been okay. I think we've had basically good people for the most part in those roles, but it's been difficult to have that relationship when people keep changing. And Jeff Kubish being as the COO now, that's been great, because I've been able to develop that relationship.
So he can provide the same sort of continuity that you had with Pat Radoszewski on the children's side.
Absolutely, and it's happening, although his tenure there is a lot less. Mm-hmm. But I think that's been a really strong relationship with Jeff as well. He and I work really well together, and I like to feel like I have mentored him as well.
Is there a point person that you have on the Froedtert, on the community physician side, that would serve the same role as a Pat Radoszewski?
So I think it's a combination of people. I have Kathy Bagamill, mm-hmm. Who's the chief operating officer.
And they had a long history working at Froedtert.
Right. So mm-hmm. I have a really good relationship with Kathy from her years of being clinic ops leader on the Froedtert campus side. And then in addition to her, there is Randy Newman, who is the chief financial officer. And I need to also mention John Nykirk, who is the executive director for revenue cycle for Froedtert. He and I are very, very, work really well and closely together. We both manage together the enterprise registration and scheduling area. So I think it's been a very strong working relationship, a lot of trust within those folks that we've worked with over the years.
Now, as we look at your office and your programs, one of the big changes that impacted the practice, both the adult practice as well as the pediatric practice, was Epic. And were you here, and how were you involved with the rollout of Epic? And what's the impact
Yes.
of Epic on your operation?
So yes, I was here during the very beginning of both Epic implementations, both on the adult side, Froedtert and Children's Hospital of Wisconsin, and 2 different Epic systems. I really, really wish that the campus could have come together with one. I think it would be a lot more efficient and in every way possible, but that's not how it happened. And so we've got 2 different Epic systems to deal with for our Medical College of Wisconsin physician groups, which we have 2, both billing under the same tax ID, but they're using 2 different Epic systems as their source of truth for everything that we bill and collect for.
And you're
So,
expected to know both.
yeah, and we are able to. We developed a charge process team, which within clinical practice services that helps with both the children's and the Epic electronic processes we have. So that team not only makes sure that each of the documentation rules, etc., are supporting what we bill, but they also have been involved in all the implementations and all the upgrades to be sure that we are getting everything that we need from both systems. And that, so just to keep this sort of straight, if possible, we are getting electronic interfaces into our GE billing system, which is the back end of our billing system, from both of those Epic systems. So it's really important that we understand all the changes that occur there that could affect how that interface comes through. So it's a lot more blurred line than in the old days. Like in the old days, we, at least on the outpatient side, we got an encounter form that was filled out, however it was filled out, and we entered it in our system, we billed and collected, and that was that. Now we have a lot more within our clinical practice services area. We have to be a lot more involved in how that electronic medical record is actually built, what the tools are, how everything's set up, so that we understand what we're getting and what it's based on. And it gets very complicated from both the provider of record that comes over as well as the actual coding itself. So there's a lot more involved than there used to be. And I would say that we didn't really save any resources with the electronic medical record. I think we have maybe less FTEs on the billing collection side, but the FTEs we have are more highly skilled and therefore are more expensive. So I would say that we did not, we're sort of in the same place and hopefully getting more accurate information at the end of the day.
Well, now, one of the other changes that happened is, I believe it was the federal government came up with new coding, and so didn't
For
your
ICD-10,
staff,
yeah.
yes, and so your staff had to learn all the new coding then that was required as well. That was a challenge, from what I understand, for all healthcare institutions.
Right, and we're still going through that because because more payers are putting in more edits having to do with the diagnosis coding. So you're talking about ICD-10,
Yes,
which is
yes.
the diagnosis coding. So when we send a bill in, there are 2 codes for the physician side. There's what's called a CPT code or a procedure code, and then there's the diagnosis code, which is why you did the procedure. And you need to, with ICD-10, we changed the actual amount of codes by something like a factor of 7 or 8 more times in terms of the number of codes that are
So
there.
it's
Much more
really very
specificity.
precise and very detailed.
Right, much more specific, and it all relates to the documentation and making sure that the documentation is appropriate to assign that code. So we had a lot of work involved with that. We still are working with that, and it really did make the coding aspect of the work that we do a lot more important. Not that it wasn't always important, but important to have really good people and certified people doing that. And it's been a challenge to get that workforce up to the numbers that we need. So we've we've been putting in different strategies for that to try to retain and recruit people in the coding area.
Now, technology has changed over the years as well. As you look at the technologies that existed when you first came on at MCW and look at what we have to work, what are there some technological advances that have occurred that have really helped support your operation?
Sure, that was one of my biggest tasks when I came was, what can we go out there and get the best systems that we can, and we sort of took the approach, since we do have GE in the back end of the billing. Not that some of these systems can't also work with Epic, they can and they do, but we implemented quite a few additional technologies. For example, the first thing within the first year of me being here, we implemented a claims scrubber back then it was called Claims Manager, or maybe it was even called Metacode, if I'm going back really far. That company's been purchased and repurchased, but basically it's a claims scrubber that looks at all the different criteria that a payer would look at, so that when you send the claim out, it's as clean as possible. Yeah. The process, the whole concept being, if you send out a clean claim, you'll get paid quicker and you'll have less denials. And so we put that into place. We have hundreds of edits that we created to make and they're payer specific, because the payers have different rules, in order to maximize that technology. So that was the first thing we put in, like I said, 2001 or so. And then after that, we decided that we needed to do something. In fact, one of the things that I heard in my original interviews with all of the department chairs and administrators when I first arrived, I went around and did all those introductory interviews, is their concerns was, okay, Marion, I know the days in IR look good, and I know that your staff is doing an okay job, but how do I know that we're getting paid correctly as per the payer contracts? How do I know you're just not writing off the difference between the payment and the charge, and not looking to see what that payment should be based on contracts? So in 2003, we did a really intense review of all of the different software packages out there for correct payment analysis, and we purchased this product called MPV, which later became Experian, was purchased by Experian. Of course, they're a big credit company. I'm sure you've heard of Experian. And so we went through that implementation and were able to get about 80% of our payers on that software, so that we have this environment. It's not integrated with our billing, but it's a web-based product that our staff can review, and we have reports, weekly reports, to see what are those opportunities where those payers have not paid according to contract. So that was a really important thing, and we still have that product. So that's and we're also using it for our community physician group as well. So that was a really good thing. And we probably get between 1 and 1.5 million of additional payments every year because we have that product in place. So that's a really good thing. The other thing that we did is one of the biggest things with registration and scheduling is that when a patient gives their insurance card to us, when they're first time a patient, or when we're asking for it over time, we wanted to have an electronic process to confirm with the payers that yes, indeed, they have that insurance plan, yes, indeed, they have those benefits. So we implemented what's called an eligibility verification system, and that works with Epic, because since Epic is our registration and scheduling system, so we have a contract between Freighted and MCW. It's an MCW contract, but both entities make use of it, so that we consistently, both when the patient's on the phone, as well as if the patient came through another organization, like a clinic appointment that we didn't actually make the appointment, sure, we have work files and work queues within Epic that we are checking, about 7 days before that patient comes in for an outpatient appointment, to be sure that that insurance is valid. And so there's a lot involved with that, and so that was another huge technological improvement. It's called real-time eligibility that we put in place. So that was, I want to say we started that process when we went up with phase 2 with Epic, which was 2012. But before that, we had that product in sort of a batch mode. And we implemented a real-time mode for with the 2012 upgrade. So that was a big improvement on that. And these products, you don't just implement them and just sort of sit back and hope they work well. You have to do a lot of tweaking and
Yeah.
updating and testing and making sure that you're consistently getting the right information back, and that you have all the payers set up that should be set up, and all the information's accurate.
Sure.
So there's a lot of effort involved in each one of these products. But we find that the cost benefit of them is positive. So.
Yeah, it's safe to say that you're really responsible for the lifeblood of this institution in terms of bringing in the funding that we need to be able to support all the things that MCW does. Estimated between 70 and 75% of MCW's income really comes from patient care. And so your office is really the one that's tasked with making sure that we have that flow of funds. At the same time, we are one of the largest practice groups in the United States. So we have a tremendous number of physicians that we're serving with the work that we do. As you look at the work that's going on here at MCW, how is our program different from some of the other academic medical centers that you talk with nationwide?
I think one of the things that we've been able to do in terms of the contracting piece, being able to contract as one physician group with the children's and the adult side together has given us enormous leverage. And as you all know, Children's Hospital of Wisconsin is a very large piece of why we're able to leverage our academic practice group with those two pieces. So that's a big plus that a lot of other organizations don't have. Certainly University of Colorado, where Jane Shoemaker is now, they have a similar single practice under one tax ID. Yeah. But I think that is unique, basically unique. A lot of the pediatric practices are separate and under the hospital's tax ID, and so I think that has helped us. Sort of all boats rise. No negative to children's, just positive to the overall enterprise has been a really big, huge thing. I can't say that enough, how important that's been for us. And I think a differentiator. The other thing is that we've been able to, we have not gone through a professional billing implementation of a new system. We've stayed on GEIDX, and I think that certainly that has helped us a lot with bringing on community physicians, for example, because we were able to just plug in what we had in place already, which is the front end Epic, the back end GE. So that's been helpful. I don't know if that will be our future, but that certainly has helped us in our current role. And having centralization of billing the way that we centralize it is somewhat different than a lot of other organizations. A lot of organizations have their coders embedded in the departments. And in some cases, some of the follow-up is done in the departments, even though they use the same system. So I think that has given us an advantage to have standardization, be able to do things quicker and optimize our processes. Then obviously it's just the matter of having to go to all these different departments, and in these other organizations they do things differently. We have a lot more standardization, and we're able to cross-train and fill in the gaps when there's a shortage in one area, which you can't do if you're not centralized. So I think that's also been really helpful to us.
Your program has been recognized nationally as one of the top programs of its. Tell me about the recognition that you've received and why your program has received the accolades that it has.
So University Health System Consortium, now called Vizient, they have a billing and collection survey every year that they've been running at least for 10 years or so. And they've been ranking, I think for 7 years, they've been ranking the organizations that participate. And we've come in the top 10 for all of the years they've been ranking the academic medical centers. So that's been a really good thing. And their ranking is based on some of the things you might imagine, like days in accounts receivable, net collection rate, but they also rank the cost of the organization. And I think the thing I'm most proud of is our cost per claim data, and also our denial rates, which are really low compared to the other organizations. And I think the denial rates being low is a testament to our software that we have in place, all the things I told you about for the technology to get that all done before the claim goes out the door. And the I would say the cost per claim is because we are so centralized and we're able to, that economies of scale has helped us tremendously. When we brought on community physicians, that also helped us with our economies of scale. So you want to be big, but you also need to pay attention to all the separate practice. So it's that combination of being large enough to take advantage of the economies of scale and be as efficient as possible, but also to make sure that we don't lose in that being too big the attention to each of the different units. Each of the departments, each of the practices have their own specific accountabilities, if
Sure.
you will. So we have to have people that are focused on each of the practices and departments, as well as have the centralization. So we've tried to do both those things.
You've created a national model in many respects, in that your program has been recognized as one of the top 10 consistently all these years. Do other academic medical centers come to see how we do things and look to you?
Yeah, I mean, we certainly have had our share of people coming in and asking. We've had consultants as well as other academic medical centers. That has happened, definitely. And we always look to others too. I mean, we've done a lot of site visits other places to see what they've done to try to improve our process as well. You're never done. You're never finished. There's always new challenges,
Sure.
And the idea is to the real secret sauce, if you will, is having the people who are committed to the organization, who are always there for you to ride the change and come up with ways to keep things going as efficiently as possible.
You've had a large team that has worked with you, and you've helped mentor and support many people within your department. Mm-hmm. As you look at the people that you've worked with over the years, I'm sure you take pride in many of them. Who are some of the ones that really stand out, who have really grown in the program here?
So I would say it's hard to pick the first one. There's quite a few, but Brian Birschbach, he is fantastic. I've seen him grow so much. He's, I always make this joke that I misspell his name, and instead of Brian, I call him Brain, because he really is a true intellectual that I have in my team. He's always thinking beyond what the question is, which it's great to have someone like that, especially in an analytical role. So he's one person. When I started, his team was basically doing reporting, not a lot of analytics, and I've seen him grow so much over the years. He works really closely with the MCW finance team, Pam Stanik's team, and helping with all of the work they do with both the monthly accrual process for our financial statements as well as our planning. We now have this 5-year plan that we do, and he's very involved in that, as well as the budgeting. Mm-hmm. So I've seen him grow in so many different ways, so that's been fantastic. The other thing I'll say is that I take a lot of pride in being able to look at, have a relationship with an individual leader on my team and really figure out where they will be best suited, where there's the best match. And
sure.
The other person I would say who comes to mind is Susie Mowers. Susie was originally, when I started, she was in charge of the data retrieval team and charge entry. She was a manager there, and I got to know her. And when this whole thing started with Epic, I made the really smart decision of asking her to lead our charge process team. and she's done a great job just making sure that everything is flowing. And we have a big percentage now of our transactions coming through that interface and making sure that all that's working. So that's one thing. I moved her into that role in, I think, gosh, I don't know how many years now. I have to think back, but at least 8 or 9 years she's been in that role. So that's been great to see that happen. And the other person I'll say, there's another individual. Her name is Kathy Lufkin-Harima. She's been at the organization, and if she retires from here, which I hope she will, I think she will be at 45 years at the medical college, her entire career. Maybe it'll be 46 years. I'm trying to remember now. 46 years, I think. So, I mean, she has, when I first started, she was the manager of reimbursement. Somehow she had gotten, Joan Albion had put her in that role. And she absolutely hated it. She was good at it, but she hated it. And she was at a point in her life where she wanted to have more time with her kids. Her kids were, sort of middle school age, and she didn't have to work. And so I created this sort of part-time position for her. And since then, she has been in a bunch of different other roles, and I have her coming back now, working for me as we're exploring what to do with revenue cycle going forward. So it's just so great to see an individual like that with so much knowledge, who's been in so many different roles, and being able to keep them in an organization, because it's so easy to, when somebody comes to you with an issue, that they can no longer fit into your little peg,
Sure.
your little hole there, that you just say, okay, well, it's not going to work, see you later. But when you have someone who is so versatile, so smart, so flexible, knows the organization so well, and has that wisdom to find a way to be flexible with that person, to keep them on board and keep them working with you and have a future, I'm proud of that. I could go on and on. How many more people do you want me to talk about?
But now, when you look at MCW as it was in 2000, when you first came here, and look at it today, what are some of the most significant changes that have really occurred within the institution or within our campus with our other partners as well?
I think the biggest changes we have are, I think we're on the precipice of this question about what should we be in the future, especially in the clinical enterprise, as we see the landscape change. So I feel like there's going to be a lot more changes to come than we've had right now. So the idea is, how do we prepare for that change? And I think that's what the organization is grappling with now.
We talked about the changes that have occurred. What's the same? Earlier you talked about integrity, you talked about honesty.
Mm-hmm.
Is that something that's in the DNA of this institution? Are there other things that make this institution a consistent entity, things that you would have found back in 2000 that you still find today?
Yeah, I think the focus on the clinical work, and I don't want to sound negative about Penn at all, because I think that's a great place, but we're not full of ourselves here. And I think there's a lot more realness to what we think we're good at, that's actually true. I know that sounds kind of vague, but
Sure.
But I think that's still the same, and the importance of the patient that I see with the physicians that I talk to, that yes, it is true that they may have a research project, or education is also important, and they're here because it's an academic place. But the clinical enterprise and taking care of patients and helping people in that way is, I think, the same, if not more of a focus than it was back then. And I think that's good.
If someone was considering a position at MCW, what advice would you give them?
I would tell them that it's a great place. It's a great place to work. One of the things I didn't talk about before, and this will sort of answer your question a little bit, is in my work here, I've never had anyone tell me, Marion, get your nose out of that. It's none of your business. Everybody is like interested in, if I am interested in something and I hear about something, like, I'll say, it could be something as far-flung as the use of the MRI equipment that we have, or something that is going to talk about capacity and how we can improve, or a report that we were looked at nationally for us to drill down to the information to be sure it's accurate. No matter what it is, nobody will tell you to, that you're in this little box. You can get out of that box by just wanting to have the interest, and people will allow you into these other areas, which I think is unique. I mean, very unique as an organization, that people are happy to have you involved. If you have an interest in something, they'll welcome you with open arms. And so I think it's that intellectual, wanting to get the best outcome. And there's not that ego piece of you can't be part of this because this is mine.
Sure.
So I think that is, if I can, I don't know if I'm explaining it exactly
No,
correct,
yeah. Mm-hmm.
but I think that's really unique here. So I would, if someone's asking, should they work here and they're offered a job, I would say, it doesn't even matter if that particular job is your match, getting in the door because it's a great organization. I would say go for it.
Thank you, Marion. I appreciate you taking
Sure,
time, and thank you
sure.
for everything you've done for MCW.